Thank you for the introduction, Dr. Tarek. Assalamu alaikum. Good morning, everyone, or good afternoon. Today I'm going to talk about endobariatric updates, and I think you need some endoscopy chill after Dr. Nadia's session. Dr. Azam, there is no relation between obesity, treatment, and microbiota, just to be honest. So, this is a global issue worldwide. It's not only internationally, but also in UAE. This is a data from Ministry of Health showing that obesity is common in UAE, like other countries. And if you notice here, how do I go back? Okay, if you notice here, the UAE average obesity rate is approaching almost 28%. And somehow Northern Emirates have more obesity to start with compared to Dubai and Sharjah, for example. Have no explanation for this, but this is according to the data from our Ministry of Health. It's more common in males and females, and unfortunately it's building up with time. And you can see that the overweight rate is coming down. And this is a good news and bad news at the same time, because most of those overweight actually join the obesity graph after that. Another example is example in USA. It's estimated that 101 million people in US have obesity. Out of those, oh my God. Out of those 101, there's 24 millions with severe obesity. Only 1% get treated with surgical bariatric procedures, and this is because of variable reasons, side effects, insurance, and other stuff. About 5% receive pharmacological treatment, and this is lately increased to 20% after the GLP-1, as we saw in the previous. And I think the role of endoscopic bariatric is lying somewhere here, so we can act as a filling the gap between pharmacology and surgery. So, I mean, at the end, we are all friends. The thing is, we have so many things to offer our patients, including GLP-1 and the friends, GIPs, glucagon receptor, and so on, surgery, and endoscopic bariatric procedures. In the recent days, there is a huge expansion of the GLP-1s, and in the past, we were talking about 5% weight loss with other pharmacological stuff, but nowadays, we are talking about 20-25%. Reaching sometime to a surgical results. Somehow, as I mentioned, we are lying in between, and I think we can work on this by covering the gap in between the two. So those patients who are not tolerating the medications, those patients not eligible for surgery, I think we have a room to accommodate them for endoscopy. It's a big menu. I'm not going to talk about everything, but this started many years ago as straightforward as balloon, as what it reached now to more advanced procedure that I'm going to talk about soon. So I'm mainly going to concentrate on post procedure because this is lately had much of attention because there's progressive improvement on the technique and evolution of the device itself and the technique and the results. And then I'm going to talk about some of the future promising endoscopic procedures. So as most of you are aware, POSE is a primary obesity surgery endoluminal procedure. It's a platform with a transporter with 4 channels. You can use one channel for a scope to make the view clear for you. And then the other channels, you can use the G-Lex to retract the tissue. The other one, you can use through G-Prox to hold the tissue and then to apply the application using a G-Cath. When this procedure started around 2010, or even before that, the results was not very encouraging, unfortunately, because primarily of the technique. Nowadays, in 2018, we started to improve this technique, and we're starting to have data showing a better result than the old days. And more recently, in 2022, even the technique became better, and the results are much better than before. I'll show you the evidence in a minute. So Y-pose cinch is, Y-pose procedure might be considered one of the best procedures. I think the size of the bites is a big one, so each bite takes about 7 centimeters. So imagine if you combined, like recently, the double helix techniques, those 7 centimeters go up to 14 centimeters. And the other thing are the sutures of pose are expandable, and they work as, the force is distributed. So the durability of the procedure might be much better than the other procedures. So this is the technique that has been changed recently. I mean, in 2018, rather than doing only the fundus and the incisura, nowadays what we are doing is we're working along the greater curvature, and we are applying 18 to 20 cinches along the whole greater curvature, making a short and narrow stomach, okay? Compared to previous technique, which we were working at the fundus and incisura only. This technique has proven better results than before, and the study here from 2 centers in Spain and 1 center in US showed total body weight loss of almost 16% among those patients who underwent this procedure. Another study from Spain looked at this as well. This is a single center, but they looked at 42 patients, and the data showed that almost 18% total body weight loss after 1 year. Another data from US, Birmingham, Boston, showed close results. And there is a pivotal FDA study going on nowadays, and we are expecting the results soon. It includes multiple US centers and European centers, and this is primarily done to approve this procedure for weight loss rather than tissue approximation as it is. Regarding the durability, this is a case of endoscopy done after 3 years, and as you can see, the sutures are still maintaining somehow. Most importantly, the stomach still narrow, and if you see the barium here, you can see how narrow the stomach still after 3 years. And this is what we're talking about, the durability of the procedure itself. So what's the problem with the 2018 technique? It's the number of the cinches that you are making. So we talked about 18 to 20, and this is really not a cost effective. So a group from Spain, Technon Center, came with the idea that rather than doing 1 bite each, we can do 2 bites at each time. And this is it's a double helix technique, and you are taking 14 centimeters of bites rather than 7, and you only apply 6 to 8 cinches along the greater curvature, with a result similar to the 18 to 20 cinches that I talk about. So the way to do it is you apply your helix to the gastric tissue. You take 1 bite with 1 helix, and then you use the other helix to take another part. So a 7 centimeter, another 7 centimeter, and you combine 2, and you get 14 centimeter bite. And this is the way how to do it. So this is the first bite I was talking about. This is the G-prox. You pull up, you start at the incisura area, and you go along the greater curvature. You take the first bite with the previous helix, and then you use the second helix to take the second bite, and you indulge both of them into the G-prox. After that, you pass your needle through the tissue, you release your first tag from this side, and then you open your device, you release the second tag, and then you start cinching. It's very important to have a good assistant with you, and I'm fortunate to have Fresi and Gilbert there. You can see him, his hands are itching, he wants to jump here. It's very helpful that you have somebody who's very well trained, because they can keep a good view for you, they know when to use the suction, inflation, and so on. So this is the first bite, and you sort of do the same thing along the greater curvature. And this is the end up result. So when you finish, you almost cinch that area from incisura to the fundus by using only 6 to 8 cinches, and that's really a cost effective. This is a retroflexion in the antrum, and you can see how big is the bite. Complication of such a procedure is considered one of the safe procedures, but you have to be very careful, not from the needle itself, but from the device, because bleeding, perforation rates, although they are very small, but they can happen in non-experienced hand. So this is very important to have a good training before starting such a procedure. Okay, so that's about pause, and I think it's very important to that we have to know that there's something coming in the future, and the other things are some of the future endoscopic procedures. I'm not going to talk about everything, but I'm going to concentrate among the most interesting stuff. This is a new procedure. It's called EndoZip, or a robotic sleeve. What you do is you get this device. It's a big suction device. You suck the tissue inside into the device, and then you sort of press one button, and then it releases a set of sutures, 4 to 5 sutures at the same time. And then you do this 4 to 5 times along the greater curvature. The good thing about this, it doesn't need much of a training, because all what you need to do is to do the suction, and then you press the button and you release the suture. So this is one of the techniques that we're waiting for a larger study now in Spain and Italy, but the preliminary report showed a total body weight loss of 13% from a single study in a single center. The other thing is, which is FDA approved, is something called the Plenity or Genesis tablet. This is it's made of silicone and with a citric acid binding the bonds between the silicone, and what you do, you swallow it, and then it releases several small particles which absorb water, and then it inflates your stomach and it causes early satiety. So it's not early satiety, but also it mixes with food, and it makes the absorption of the food much slower. The study they looked at 400 patients. This group drank only water with a placebo tablet. This group had the Plenity, and as you can see, there's not a big difference between the two. We always tell our patient if they drink a glass of water before meal, they can lose 4 to 5%. As in many studies, there is a subset of a group which goes beyond, so we have almost 27% who lost more than 10% on such tablet. A similar idea came from an Oxford group. They looked at, they made some changes, and now they made it a hydrogel, dual hydrogel platform tablets, which actually can stay and cause satiety for 7 days in your stomach. So this is somehow similar to what GLP's injection doing, and I'm always thinking about combining both of these things. I mean, we have tablets which work for 7 days, and we have an injection which work for 7 days, and we can alternate between the two. The 2A phase study has finished and showed safety. The preliminary results showed a 10% total body weight loss in 3 months. Moving to another technique, which is the duodenal ablation technologies. All of you are probably aware about hydrothermal techniques and fractal, injecting the water submucosally and then applying a heat. Sort of, the theory is that if you are diabetic, you have a hypertrophied duodenal mucosa, and you are becoming less insulin sensitive. So if you denude this mucosa, then you are allowing another new mucosa to come into surface with better signaling and better diabetic control and weight loss. So one of the techniques that came recently is applying hydrothermal energy on the mucosa of the duodenum, starting at the second part up to the ligaments of Treitz. And you first line your ambula with a clip, so you avoid applying the energy on the ambula itself, and you continue doing this until the third or ligaments of Treitz. And there's an abstract in 2024 DDW showed a response rate of almost 10% total body weight loss. Another technique, which is I think is promising, is a reset procedure. It's the same idea, but rather than doing hydrothermal ablation, now you are doing electrical ablation, and similar to what cardiologists are doing nowadays with treating arrhythmias. So what you do is you apply this electrical current at again at the same site. starting at the second part of the duodenum up to the ligaments of Treitz. And the idea is that you make some changes on the neural network. And again, also, you have sloughing of the mucosa probably within 72 hours, and the new mucosa comes. And this new mucosa is believed to have better insulin response. There's a multi-center trial looking at this, and they just presented a DDW abstract 2023, and we're having a significant drop of the hemoglobin A1C as well as weight. Another interesting future technique, which I think will have an implication on the management of obesity and diabetes as well, is injecting an adenovirus with a GLP-1 promoter. So what this company is doing is introducing this virus to islet cells or beta cells, because they are terminally differentiated. They are believed to be the best media for the virus, and it enhances replication of these cells and production of GLP-1. So the way to do it is you do it exactly as when you do EUS. You just introduce the virus by using the needle into the islets of beta cells. And this is a study where they look at comparison between the gene therapy, the adenovirus, and the daily semaglutide injection. This is done in mice, by the way. I mean, it's not ready for human yet. And the results are encouraging with regarding to the plasma glucose, insulin, and weight loss. It's more or improved among patients with gene therapy. And again, here they did a crossover. So this is the semaglutide mice, and when at one point, even if you are taking semaglutide, you regain weight. When they cross over here, this is a group with the gene therapy. Those groups continue to lose weight. So it might have an implication on patients who is taking semaglutide or GLP-1s in general to be in this therapy in future. The last slide I'm going to talk about is the importance of the combination therapy. We all get faced with a problem with the weight regain after endoscopic procedure. Some patients come back to our clinic, and we need to find solution for them. So I think combining therapy is one of the things that we can offer our patient. This is a study from US showed that if you combine medication after procedures, you continue to lose weight for 2 years. This is after ESG, and this is after intragastric balloon. The question is when to start the GLP-1 or pharmacological therapy. This is a preliminary data from US study showing that probably if you start your GLP after the procedure, you will continue to lose weight more than if you started before the procedure. So in conclusion, I think endoscopic therapy play a major role, especially in the gap fitting between the pharmacological and surgical therapy. There are procedures on the horizon. We think they're coming in the near future, and we're expecting good data. And with regard to GLP-1s, I think the criteria will expand. The medication will come more available to people. However, we'll start having to hear about more side effects and limitations for such medications. And I think this is the role of the endoscopy at that level. For this, I finish my presentation. Thank you.
Thank you very much, Dr. Abdulla. Unfortunately, Dr. Ali Khamas is not available, and Dr. Miriam Sandel, I'm assuming she's a surgeon, will tell us about surgery